2.
Today on Injury Territory, we talk about a terrible injury to Cody Ponce.
And we also talk to one of the innovators in both rehab and performance. This is probably a technology you haven't heard of, but people inside baseball sure have. This is Injury Territory. Hey, thanks for joining us. Thanks for subscribing, hitting like, all that crazy YouTube and podcast stuff. But we have to start out today with a little bit of broken news. Unfortunately, there was a terrible, like you said, Edward, terrible injury. Cody Ponce, one of the best stories of the early spring, a guy coming back from Korea. He'd been in the major leagues, Mexican kid, comes back, got a great deal because he'd been so good. He looked good in spring. He looked good through 7 outs. And then on a fielding play, he says he hyperextended his knee. He's going for imaging, but it's one of those situations where, look, that was the classical mechanism for an ACL sprain. I talked to a couple doctors last night. I talked to a couple people within the organization. That's the expectation. And if so, that's the season. Unless he goes down and sees Dr. Lavender, who we talked to a couple of weeks ago, even then, 6 months is not going to get him back in any meaningful way. Now, that said, I do have to remind people, Kyle Schwarber came back in season on a very similar timeline. Now, I don't think that's going to happen here, but certainly we always have to talk about rehab times, and we'll talk about that a lot more in the interview. But this injury, it couldn't be worse for Cody Ponce, but it couldn't be worse for the Blue Jays. This is a team that's already down Jose Barrios with the elbow. They're already down Shane Bieber, who's still ramping back from a little bit of dead arm and being over a year out from his Tommy John, but hasn't had a full season, of course. And Trey Savage, who's going to have a sim game, I think it's Friday. He's starting his ramp. He had that shoulder impingement. So now here's 4 guys who are expected to be in the rotation, and they're not in the rotation. And that's not good for the Jays.
No, it's not. And we were talking about this before in terms of sort of preseason expectations that Toronto really needed some breaks to happen because they were already dealing with these starting pitching setbacks like you talked about. And adding this one isn't going to make things any better here. And oh, by the way, if we look at the state of the American League East right now, looks like the New York Yankees are still really, really good. So again, you needed everything to kind of yeah, this is a fantastic division, to say the least. Even those, on the back end of it, like Boston, for instance, you still have some optimism there that things can turn out their way. So the fact that they're already dealing with setbacks and now we're adding another significant one. I mean, look, even in the small sample size of what Cody Ponce was able to do this year, there was a lot of reason for hope here in terms of his off-speed deliveries, the fact that his whiff rate was just truly unbelievable. He was going to get guys to chase and chase frequently, and now Toronto's not going to have him. It's truly terrible, Will.
It is. And let's talk about their rotation. The funny thing was, Ponce was likely to be the 4 or the 5. And this is a good pitcher. I realized not a lot of people know him. He was with, I think, the Pirates before, went over to Korea, and absolutely remade himself. And there have been a lot of success coming back from KBO. Guys who go over there and pitch well do tend to pitch well over here. And, when you talk about adding him and Dylan Cease, that was a big upgrade. It should have been Gausman and Cease, who are still there 1-2. And then you would think it's Bieber. And then is it Ponce and Yasavage and Ponce? That's still a very good 5. Obviously, they re-signed Max Scherzer. He's now the 3 functionally, and we don't know how much he has left. If you watched Justin Verlander last night, didn't look good. Did not look good. But then you're going back to Eric Lauer. Francis is out. I don't know who the 5 is off the top of my head. probably going to be somebody coming out of the pen. So I'm a little bit stumped. I'll have to look that one up here. It's just a tough one for them. Let's talk a little bit about Yesavage and Bieber. Yesavage,
Sure.
like I said, the shoulder. He's going to do a sim game on I think it's Friday, and then Bieber's coming back on the weekend. He's throwing off a mound for the first time in a while. They're both ramping, and I was on the Jays show with Kevin Pillar and Ricky Romero and the crew over there. They do a great job. My suggestion was that maybe this ramp doesn't have to be as rampy. I'm not saying rush them back. I'm saying if you get them to the point where they can throw 3 innings, instead of going the whole like with Zach Wheeler, he went 38 pitches, 37, 38 on a 40, and then he's going to go 60, 80 for the pitch targets. What if you just said, you know what? 60 pitches of Zach Wheeler is pretty good. 30 pitches of Shane Bieber is pretty good. I realize they're managing workload with him. If Yesavage's shoulder is right, can't you use him or Bieber as an opener, get 3 innings, pair him with a bulk guy, and instead of throwing to kids in Dunedin, they're throwing to major league hitters and helping the team. They're smart in Toronto. They could figure this out. So I don't think it's a matter of rotation or rote or players like roles that are known. I think this is going to be a tough division. Every win is going to count. Every inning is going to count. I'd like to see some innovation here.
We need to come up with a name for this, I think, because it's not exactly a bullpen game, right? Because these are starters who are just going limited pitch counts, limited innings, things like that. So even though the structure is that of a bullpen game in terms of having a bulk guy, it's not exactly what that is. And so I feel like this needs a new name.
Yeah.
That way
Bullpen.
It catches on and then more ball clubs do it, because I think you're right. Like if you're getting to these pitch counts and you have these targets, why not have them in actual games instead of, kind of wasting all of that effort when it doesn't matter?
Yeah. I'm completely with you there. Now you've got me thinking about, this is sort of a marketing problem. We know that Rob Manfred hates short starters, not height, but starters going a short way.
Why does he hate short people?
I'm probably going to. Here's a pitcher I do not know. Lazaro Estrada is the one that's going to be called up for Cody Ponce. So Ponce, excuse me. So in this situation, is it marketing? I don't care about the name personally, but that's part of it. Bullpen game does have a negative connotation, is that we don't have a starter. Yeah, I think for years I've been talking about, what came to be known as openers, tandems, piggyback starters. I don't care. Get the innings. If what you can get is 6 outs, great. Because I think 6 outs of Wheeler is going to be better than 6 outs of, I don't know. Taiwan Walker's pretty good, but still, Wheeler's better.
I think I got it. I think I've got the name here. Ascension Start. You need something positive, uplifting, promotional, positive.
Religious, but yeah, it's almost Easter.
Yeah, exactly. Ascension Start.
Let's workshop that one. I like it.
Okay.
You know what? That's good segue here into a talk I'm excited about. If you don't know what blood flow restriction is, you're about to. We're going to have Tyler White right after the break here on Injury Territory.
This one's for the dudes looking for that peak bedroom performance. BlueChew just dropped their newest innovation, BlueChew Gold.
BlueChew is the #1 chewable ED brand, and yes, BlueChew Gold dissolves under your tongue and works in as little as 15 minutes. Peak passion and peak performance in a single tablet. See why millions of men trust BlueChew now with a gold standard upgrade that is changing the game for good. Make life easier and discover your options at BlueChew.com. And we have a special deal for the FT fam. Get 10% off your first month of BlueChew Gold with code FOUL. That's promo code FOUL. Visit BlueChew.com for more details and important safety information. And we thank BlueChew for sponsoring the podcast. This is the future of performance. Faster, smarter, and precision engineered for results. 2 ingredients for blood flow with apomorphine and oxytocin to turn up the arousal and connection in your brain and body. It's BlueChew.
Hey, welcome back to Injury Territory. As I told you, super excited to have Dr. Tyler White joining us to tell us about, man, this is advanced. This is blood flow restriction, one of the really new, I guess not super new. It's been around. I can remember the first time I heard about blood flow restriction. It was Stefania Bell talking at a conference in LA. She was really on top of that one, opened my eyes to it. And Tyler, you've been at the forefront of this. Tyler is the director of sports performance for Owens Recovery Science and a performance therapist at Invictus near St. Louis, Missouri. Tyler, thanks for joining us.
Yeah, thanks for having me, guys.
So let's start off really, really basic. Blood flow restriction, well, kind of self-explanatory there. What is it? Why do we care about it in baseball?
Yeah, so like you said, it has been around for a little bit. It's most widely used in the training room. Think recovery post high effort performance, or more importantly, a really efficient way to get you back from injury or surgery quicker, because we can basically, so the beauty of it is we fatigue the system quickly. And essentially with that is we can now get a we can do a low load training stimulus, but get a significantly higher load response out of it. So the kind of the running numbers that we commonly reference are we can lift at about 20 to 30% of our 1 rep max with BFR and get the nearly identical output as if we were lifting or training at 70 to 80% of our 1 rep max. So essentially what's happening is we're occluding some blood flow, a certain percentage of blood flow into the extremity, and limiting any blood flow coming out of it. And what happens is it fatigues the system rapidly because there's less oxygen, less nutrients going to the muscle. So the brain freaks out. We see all of these responses happening within the system. Increased motor unit recruitment, increased fast twitch muscle fiber activation. We see VO2 max improve over certain studies or certain parameters. Vascularization goes up. So we have, new blood vessels going to those muscles or tissues that are trying to recover. And just, we see, overall endurance improve from it as well. So it's been a really unique tool on the rehab side. But lately, I'm going to say about the last 3 years, we've been digging pretty deep into the performance aspect of it.
Yeah. Now that was a lot. So let's unpack this a little bit. I'll go a little bit of frozen caveman. So explain it to me. Like I'm me, we're talking about getting more results from less effort, all by the use of a tourniquet. Mm-hmm. Is that really at the heart of it? And if so, how does that work?
Yeah, so it's a little bit more elaborate than that, but yeah, for the gist of it, yes. So there's a Doppler ultrasound within the unit. We're talking about the Delphi, right? It's very important because there's a lot of different blood flow restriction devices out there, but none have the technology that this one does. Specifically, they have a patent on the ability to know how much pressure and maintain that pressure within the system. But probably the most important aspect to be able to do kind of the explosive-like movements, such as throwing, is it has rapid auto-regulation. You can see from the video there with the box, you see it rapidly adjusting. So as the athlete's moving around, that ultrasound within the unit is detecting the amount of pressure as you move, and it's going to change as you go into scap load, layback, go into acceleration phase. Like that pressure within the arm is going to change. So that cuff is able to adjust rapidly as that pressure is changing. So it's pretty cool that it can allow you to do that. But essentially we're limiting that amount of blood flow to essentially fatigue the system pretty quick.
You mentioned one of the big wins being recovery from surgery much faster. For the casual baseball fan, what are some of the other big wins with this approach?
So on the performance side, well, the rehab side, recovery side, yeah, 100%, we can get you back quicker. On the performance side,
Holy smokes, man. We have seen, can I put a pause in that for a second? I just want to say this all started because a conversation Will and I had 3.5 years ago, talking about recovery, talking about why the UCL return to throw hasn't improved. And it started kind of spitballing into, can BFR be used for throwing? No one's done it. So like at that point, I'm like, well, I'm going to have to test this out and figure it out. Honestly, we wouldn't be here if it wasn't for Will to an extent. I will say that on record. It did take probably 2.5 years of creating new product. There was a lot of hardware that we had to basically invent to make this work. A lot of program design, but we have seen, I don't know where I want to even start. We've seen a pretty massive amount of individuals increase their velocity over time, over a 6 to 8 week period of using it. I have several dozen cases in the clinic of injuries that I have basically gotten back quicker than you would expect. To be honest, there's so many aspects to baseball that this has touched that I've never seen before. And I've worked in this industry for 10 years. I work with the highest level of big leaguers. I feel like I've tested everything. Nothing has come close to what we've been discovering with this. We're changing mechanics. We're cleaning up arm paths. We're improving lead leg.
Oh, we're having a little bit of a technical difficulty here with Tyler.
Am I still there?
We are here.
Yeah, there you are.
Oh.
We thought we lost you there for a second.
Sorry. Internet's not great here. I apologize. I don't know.
Keep going.
Where did I
We're
leave
good.
off? Okay. Yeah. So individuals that use this for a period of time, they'll say like, hey, I don't feel like I have to throw as hard. Like my perceived effort is going down, but I'm chucking, 1 or 2 miles an hour faster. They're less sore after starts. They can go longer into games without fatiguing. Like there's so many cool aspects to this that we've been kind of figuring out. And then probably in the last year, we've been testing it on hitters, and we're seeing some pretty cool stuff on the hitting side as well. But I think the biggest ROI is going to be in throwing and just the amount of injuries we have with pitchers in general. I think we can cut that down pretty dramatically using this.
Yeah. Let's talk about who's using it, because I can remember, again, going back to that initial talk that Stefania gave, it was mostly military. And obviously you have a war, you get some people coming back from injuries, and you get a lot of advanced research. You don't like the reason, but you like the result. For this, obviously in baseball, you've created the machine that's usable. It's got that long tubing that doesn't get in the way those original ones were, that were very, very short, very, very small. It just didn't work for baseball or for a lot of things. What kind of teams are you working with? What level of athletes? Are there any you can tell us about that have had a big result?
Yeah, I there's probably some I can't mention, but I can give you a few. I would say I have. So we've taught probably 3 or 4 courses now for BFR baseball. One was a semi-private. The others were privates. So we've probably had about 10 teams be integrated into this now. One I will say is the one that I'm excited about, and they wouldn't mind me sharing, is the Baltimore Orioles. Like, and they, they sent pretty much their whole crew over when I was down in Sarasota working with them. They got to see it kind of a proof of concept firsthand. One of their minor leaguers trained with a group in Arizona that I taught how to do this, and they've been doing this for pretty much 8 months now. He, in the off season, he would struggle to be, anywhere close to 90. And then in season, he would struggle to hit 94, 95, in a game. And then they started using the BFR throwing system with him, and he was, sitting 94, 95 consistently, no arm soreness, no arm pain, was feeling amazing, recovering quickly, and, felt like there was less effort needed to do so. So when they got to see that, and then they got to kind of talk to this individual as one of their minor league pitchers, what his thoughts were, they were sold at that point. So they've definitely taken probably the most aggressive approach so far. On the big league side, we have a handful. I probably have 10 to 15 big leaguers that have their own units that I've taught how to do this. Some of them I'm not allowed to talk about yet just because the teams aren't totally bought in fully. I would say 80% of said teams are bought in, but a few of the decision makers aren't completely there yet. Excuse me. One, I think that would be an interesting one that I can talk publicly about would be like Matthew Liberatore with the Cardinals. The Cardinals did like a day in the life of his training in the offseason, and they flew out and did all this stuff, and he was doing some BFR throwing with it. So that's all public. That's all out there. So like that's one for sure. It's be interesting to see. And then that same group down in Arizona, they were working with like Dennis Santana with the Pirates, and there was a couple others in that group. But I will be really excited to see kind of our end result. The one interesting thing is not everyone trains at the same level of intensity. So, there's some individuals where we say, hey, your biggest need is going to be training up your lead leg block this offseason. So we would spend the majority of time there. We might hardly even put it on their arm. So like everyone's going to be a little bit different, but the kind of the cool thing is every single individual has had a pretty cool response from it to the point where they're like, man, this is crazy. Like this is pretty unique. And, we have all this research we're working on. We have some that should be getting published here rather soon. Like we did one at Point Loma in San Diego at Point Loma University, Point Loma Nazarene University, looking at the ability to warm up more effectively and sooner with less throws. We have some looking at a 6 to 8 week throwing program just on the overall velocity, spin rate, endurance, strength index, both the shoulder and like grip strength. We're just going to throw everything at it and see, what we can find in terms of data. Because we've seen it over the last 3 years. Like I have tested all of this stuff on probably close to 1,000 throwers now from high school, college to the big leagues. And we've seen it. Like I have it documented. It's just we got to get it published now.
Right. That's always the tough part.
Yeah, Tyler, I'm glad you brought up this idea of individuality when it comes to figuring out, what pressure, when to wear it, all of that. And I'm curious from a general perspective, how you handle the off season versus in-season implementation.
Yeah, so both are very beneficial and unique. So off season is like, hey, let's shake off the rust. Let's build up our workload in an intelligent manner. Because that's how injuries happen. Workload spikes. So we're able to do so, build them up efficiently and effectively, and then continue to enhance and progress that overall workload. And then as we get closer to the start of the season, we'll taper off a lot of the BFR usage because I want them to have in-season game-like stimuli. So we will, build up the bulk of what we're looking for, and then start to just kind of chisel it down, and then boom, you're ready for the season. In season, I think it's going to have a dramatic effect league-wide because now we can maintain a high workload stimulus with less stress. And we're thinking about starters having to go, every 5 days, throwing anywhere from 90 to 115, 120 pitches, depending on, who you are. You got to try to find a way to get that stimulus in season, still, get the work in, but not be too tired, too sore. You want to be effective. And now just looking at the basic science behind how BFR works, it makes a ton of sense. Like we're having to put less stress and effort into catch play, maybe a midweek bullpen, but getting a high workload stimulus out of it. So now we're basically staying pretty clean, pretty good, as close to 100% as possible throughout the season without that risk of workload spike.
I'm going to vastly oversimplify this. Let's say a guy goes out and throws, this is too low, but a 50% bullpen. And you're saying he could get something on the order of 95 to 100%. Again, I'm vastly oversimplifying. When we're talking about workload, it's normally done in throws. This might be a multiplier for that, or do we think it's less? How's the body's response to this in terms of both acute and chronic workload?
Yeah. So numbers wise, it's probably not that cut and dry.
Yeah.
But you're not wrong in like the abstract thought. So, we don't have a firm answer yet on exactly, is it a multiplier? What's the actual like change within the system in terms of workload? I have done preliminary testing with a couple dozen individuals in-house, both college and professional, using a pulse just to try to get like a workload idea. And across the board, when we kept intensity, number of throws the same, we were zero point 0.5 to 1.5 acute workload less than what we would typically see when we did like a control or compared to like without the BFR on. So there's definitely kind of a twofold scenario where it's like we can get to our workload sooner with less throws, or we can build our workload capacity up higher and still stay within our parameters of what we're chasing in terms of arm stress.
So where exactly do you put the cuff, on the arm? How much of that is dependent upon what you're exactly trying to accomplish? And is this something, since I know you talked about it's sort of an inconsistent thing where it adjusts depending upon the actual throwing motion, how do you make sure that the restriction is not too restrictive on any one particular individual?
Yeah, so we set our pressures for the arm at 50. That's kind of our baseline pressure for occlusion. So that's 50% of our arterial blood flow going into the arm is going through there. And then we can adjust it depending on the individual, but probably 85 to 90% of the time we're going to stay at 50. And it's going to be, as you can see on the upper arm, the proximal end of the extremity. Sometimes we might adjust it kind of determining by like their arm slot or how they rotate, how they throw. So that's just going to be kind of different by the individual. But generally it's going to be pretty consistent throughout, whoever you're working with or what you're doing. There's just a few rare cases where you might change the pressures.
Now, obviously, you can't use this for the shoulder just because there's no place to put the tourniquet. Do you feel that's a limitation? Are the shoulders going to fall behind the upper arm and forearm in this case?
No. So there was a pretty big study that Lambert's group did out of Houston where they looked at rotator cuff strength, basically looking above the cuff. And there was a statistically significant change in rotator cuff strength using the BFR. So there was a kind of upward system approach as well.
Correct me if I'm wrong. There was also a study that showed gains on the opposite side where the tourniquet wasn't.
Yeah, I think they don't quote that as much. There may have been some conflicting stuff in the methodologies, but yes, that has been published.
Also, too, when you're rehabbing players, are there ever instances, obviously BFR is what you do, but are there instances where you go, maybe this isn't the best process or best approach for this particular player?
Yeah, there's a few contraindications. Like if someone has, unstable high blood pressure, probably not worth doing. If they have an acute, like a current blood clot, not worth doing. There's a couple other more rare contraindications. But if you cross those off and probably the overwhelming majority of baseball players are not going to have any of them, then it's totally safe. And that's kind of the beauty of the Delphi is all the safety mechanisms built in. It's the only FDA regulated BFR device on the market. Like it's pretty ironclad. So like in terms of safety, like, the size of the cuff matters. Like they have wider cuffs, they're conical shape. So it matches the kind of the shape of the extremity as it narrows so that the pressures stay consistent throughout. There's the auto regulation piece, making sure your pressures are the same. Like there was a study done last summer where they compared the most common BFR devices on the market, and they showed their ability to maintain pressure both in exercise and at rest. And Delphi was the only one that was consistent through all the participants. And it's a pretty alarming study when you see the graphs of all the other devices. You're like, holy smokes! Like we're taking a guess at that point. It's crazy.
Yeah, there are a lot of other devices, and this is not something you should. Don't try this at home. without a professional, without a trained professional. But there are other devices out there. I know there are some that are simple straps. I remember seeing one that's built into a shirt that accomplishes similar, but it doesn't have that reactive sensing safety, I guess it would be at some level. I mean, obviously, it's not adjusting more than literally you pulling a Velcro strap, which does get some of the gains and is certainly a lot cheaper. But also, you don't want to be messing around with tourniquets if you don't know what you're doing.
No, that auto regulation piece, that rapid adjustment of pressure, like so before I started all this, I tested virtually every device on the market, and I wanted to see, can we repeat the same results with all the other stuff? And pretty much within the first 10 throws of every other device, I just stopped because I'm like, there's no chance. This is not safe. It's not comfortable. It's just, it would mess everything up. So right off the bat, I knew like, hey, this is the only device I could replicate this with.
What are some of the possibilities with lower body blood flow restriction, and how relevant is that to this discussion about rehab and performance?
Yeah. So the rehab side, again, it's like if you have some lower half injuries, you can build up strength with less load, but also how do we integrate into our performance? Is it something you did on your drive leg and now you can't, create any force out of your back hip? Well, we can now put the cuff on and basically mimic those movements that you're trying to get, the directions you're trying to load, and we can build that up quicker under less load. And then on the performance side, we might see some mechanical flaws that they're loading maybe incorrectly. It's creating some chronic issues around a certain muscle or joint. They know they need to change it. So we can design programs and drills to start changing the muscle activation pattern, the neurologic pattern, the muscle tone, and we can start building that up. And same thing with lead leg is like, that's probably more common than the back leg, is individuals sometimes don't have the best bracing. And there's so much in the mechanics of the throw and velocity of the throw that brace needs to be great. And it has to be quick and it has to be efficient. And we have seen some pretty dramatic results with that. And we have a force plate mount here in our clinic, so we can do all this testing in house as well. But I've had several players that, like I had a couple minor leaguers that struggled to feel that brace. They'd feel almost squishy when they'd start to play catch. And we could strap that on, throw 10, 15 throws with it. And then like, boom, it was there. And they were back to like, hey, I feel it. Like it's snappy, it's quick, it's sharp. And what's cool is like, it's not just activating more muscles. They'll tell you like, I feel like my pelvis is unlocked. And I think what's happening here is neurologically, we're turning off the need for some of that like postural tension from certain muscles. So it allows the whole system to start moving the way that they want it to, which is really cool on like the warm-up side of things.
I think also, as you're talking about this, that it is something where the lower body meets the upper body, and then, you sort of make it go hand in hand. I think at the same time, since we are so early when it comes to the overall research of this, like you were talking about before, what are kind of those next steps? What do you want to see in terms of the next strides to feel comfortable with not necessarily just publishing more things, but also really being an advocate for your program?
Yeah, I would say, we have the results. So it's more so like, let's just start publishing them. Let's put together a process that can validate it and publish it. But I think more along the lines of like the why we need to keep digging into, because it's very gray. Like we don't have firm ideas of why we're seeing the results we're seeing. And I would like to get there because the results we're seeing are unlike anything we've seen in baseball. So we got to get more answers on that end. And we have a lot of theory, and there's been, hundreds and hundreds of papers published on BFR in the past, looking at different measures, doing different things, different methodologies, but not in throwing. So that's where like this is a completely new territory that we're trying to kind of now say, hey, this is something new. We're seeing some pretty incredible results that we've never seen before. Let's figure out exactly why that's happening. So that's probably our next step. And then just more widespread integration. I'm at probably a little over 1,000 case uses. I would like to be at like 20,000. I want to see way more people. I want to see more responses. Because even in those first 1,000, man, we're seeing stuff we've just never seen before. Like a month ago, I had a guy in, college pitcher, flexor carpial ulnaris strain. And I had him back at 100% on the mound right at the 21-day mark. Like to the point where he was like, dude, I feel nothing. This is amazing. And he was throwing harder. He felt better. So like virtually every individual that I've had come in with an injury, we've gotten them back significantly quicker. And then they are better than where they were pre-injury. Like I had a kid come in this was 2 years now. This was early. Grade 1 UCL sprain, told basically, 3 to 6 weeks, no throw. We started throwing right at week 3. It built him up in that time frame, and he was 100% right at the week 6 mark. And he probably had another month and a half of, if you're no throw for 3 to 6 weeks, then you got to build back up for another 4 or so weeks to get your workload built up. And then, he's off and running. We had him 100% at week 6, did a couple more weeks of throwing. He went to school for his fall season, texts me, says, hey, arm feels amazing, best it's ever felt, but I'm also throwing 2 ticks harder than I've ever thrown. I'm sitting my previous PR. And he was just cruising the rest of the fall season, like amazing. And I'm like, all right. And again, this was early. I'm like, there's something here. And we have been able to replicate this pretty much over virtually every injury. I've used it on TOS patients, ulnar nerve patients, virtually anything at the elbow. Have a recent slap tear that was trying to go non-surgical, and we got him to be able to throw it like 70, 80% at 200 feet, where he couldn't throw a plyo ball a week prior at 20% without a pinching pain in his shoulder. And it's like, hey, we can now load him quicker and sooner and more aggressively and get him back. And not only are we getting him back, but he's better than when he was before. Like, that's profound. It's crazy. Like, the stuff we're seeing is nuts.
Tyler White, let's talk a little bit about your facility. If someone wants to, if they have an injury, if they want to do some training with you, how can they find you? Tell us about Invictus.
Yeah, so Invictus Performance Therapy, I work primarily with baseball players. At the professional side, I'm only pitchers. I had a year where I had a wait list, and I had too many people wanting to reach out. And I was like, you know what? My biggest ROI is with pitchers. I can potentially change so much about their future. Whereas hitters, I can make them better, but it's not as dramatic. If you're local, obviously St. Louis, I work primarily in baseball, high school and college level. I do have a handful of college guys that'll fly over for a full, I do like a big league evaluation, like I do with my big league players. And then on the big league side, if there's you're dealing with injury, inconsistency, something is wrong, or you just want to try to basically get the most out of your career. Like I had, InvictusPerformanceTherapy.com. My email's on there. Reach out. I have agents reach out all the time, basically to have that same conversation. But that's best place to find me.
That's Tyler White from Invictus and Owens Recovery Science. Thanks so much for the time.
Thank you, guys. I appreciate it.
Thank you.
Hey, welcome back. Injury Territory. Will Carroll, Edward Egros. And wow, Tyler White gave us a ton to unpack. This is something I've been following, like I said, for years. I've known Tyler. He gives me far too much credit for the idea, though I do remember that conversation very clearly. What you think, Edward? This is not something that you've known about for years, though you asked some great questions.
It's fascinating to me that when it comes to sort of risk tolerance with ball clubs and individuals, things like that, if you are someone who needs to, say, gamble when it comes to rehabbing, coming back, things like that, then you're probably likelier to look at all of your various alternatives. And so blood flow restriction makes a whole lot of sense there. And then also with other ball clubs, I mean, the problem is sort of like how we wrap things up, right? It's data. It's, what are the long-term effects, those kinds of things. And really with any medical innovation, I would assume you're not going to know all of that for quite some time. And so those who are risk averse may not, want to go after something like that, even though certainly the early results are promising. And I also like this idea of, sort of the the song, knee bone connected to thigh bone, all of that stuff, that what your lower body can do in terms of blood flow restriction can impact the throwing motion and vice versa. And that to me is really exciting to kind of remind all of us that the body is very much interconnected. And it's not just one thing you're trying to fix, but sort of an entire process in terms of making sure that someone can go out there and have a healthy start.
Yeah, it's stunning to me how quickly this has come along. The initial research I remember seeing was on older people and military veterans that were coming back from injury, and they could do like 20-pound squats and get like the gains of doing 100 pounds when they just simply couldn't at that early stage. And then of course the bodybuilders and powerlifters got in there, and they're a little bit crazy, and they were like, if I can do more with more, how much more do I get? And with this isn't something that's new. It's something that's developed. You doing it for throwing simply didn't exist before Tyler put in the work and created a machine that could do this, in part with the long tubing. I mean, I think that's one of the things that a lot of people think is off. Let me play the video one more time. That's the machine that you get a brief glimpse of. It's very small. It looks like an old iPod, but you can see that arm and the tubing kind of whipping through. And that was the big problem: is did the tubing get in the way? And there are two tubes. That black tube there is actually the air that goes to the tourniquet. The other one is kind of I think it's the outflow. I forget which is which. But it has to be able to squeeze and not squeeze, and then not get in the way of the throwing motion. The machines they used to have for squats could be, big boxes with a little tube of maybe a foot, because you could be right there. It wasn't, a normal throwing motion. So I'm excited to see this. I don't think it's risky. I think they've worked that out. I think some other devices, much more primitive, could be in the wrong hands problematic. Tourniquets, you just don't want to put a tourniquet on too tight and leave it there. Bad things happen. Hopefully people would have common sense, but we've seen that's not always the case.
Common sense isn't exactly common.
Yeah. The other thing that was interesting to me is some of the teams he did name. It's the usual suspects of smart teams. Is there a reason these smart teams are usually fairly successful? Yes. I'm curious to see exactly where that goes, because the Orioles have had some pitching injuries. They've got a great medical staff over there. I'm curious to see how that goes. Obviously, the Cardinals in a rebuilding phase. If Liberatore can come out and be a real, maybe not ace, but a guy who's occupying that spot that makes them competitive, and then 2-3 years when they get some of these pitching prospects up that they've traded for, whether that's my favorite guy, Gerangelo Cinci, who would need 2 cuffs for his workout. It's really intriguing to me to see how quickly this is coming. And I think in 2 years, this is going to be table stakes. Every team is going to have one of these. They're not so expensive that colleges can't have them. I do think early on, we're going to see people having to travel to Invictus. I think there's going to be a couple centers where people go, but that's kind of the case now. You could go down to Kinetic Pro, you could go to one of the farms, or Randy Sullivan's is the Armory now, excuse me. There are places that people know, Driveline, of course, all over the country now. Kyle keeps growing. So it's interesting to me to see how this is coming, whether it can not only speed up some rehabs, but increase some performance. There's not a lot of technologies out there that do both. And for me, the most exciting part is, if you can combine this with a more advanced surgery, an internal brace, or like Chad Lavender's fertilized knee, how quickly could you get somebody back if you're starting to stack these things? And you know what? I got to tease this. I'm not even sure I've told you this, Edward. Coming up next week, we are going to have a talk with Dr. Jeffrey Dugas of Andrews Sports Medicine in Birmingham. He is one of the, if not the leading guy. He did most of the work and research on internal brace for elbows. It was developed for all sorts of things. The first time I remember seeing it was in ankles in European soccer. But Jeffrey Dugas, one of the top sports medicine surgeons down there in Birmingham at Andrews, we're going to be talking to him next week. So I'm excited about that. Edward, as always, thanks to you. Thanks to Tyler White. Thanks to the crew at Foul Territory. This has been another episode of Injury Territory. We'll see you next week because the injuries just don't stop.